Good morning, all. Today, our topic is medical management of glaucoma. The goal of currently available glaucoma therapy is to preserve visual function by lowering IOP, and the treatment regime we should choose to achieve this goal with the lowest risk, fewest adverse effects, least disruption of patient life, and taking into account of the cost also. The long-term efficiency of treatment is judged by stability of the visual field, optic nerve, and other structural parameters. Also regularly assisted by ensuring the adequate IOP reduction. And the time target pressure is refers to an IOP below which the clinician estimates the rate of disease progression to be sufficiently slow as to minimize the patient's risk of experiencing further symptomatic vision loss in his lifetime. The value of establishing a target pressure after an initial evaluation period of patient with glaucoma or ocular hypertension is that it encourages thoughtful appraisal of various clinical factors that influence disease progression and allows for an efficient assessment of IOP in each visit. Even if the target pressure is achieved, the clinician must continue to evaluate the functional measurements and the structural that are important for the glaucoma. And target pressure should be individualized for each eye based on the IOP level at which damage is thought to have occurred and the severity of the damage. It can be adjusted on the basis of several factors like the previously observed the rate of progression, life expectancy of the patient, risk factors such the disc hemorrhage, thinner cornea, and family history of visual loss in setting of glaucoma. And the severity of optic nerve injury may increase the likelihood of continued disease progression. So, more advanced the disease in the initial presentation, lower the target pressure required to minimize the risk of further symptomatic visual loss. And if severe visual loss is already present, further damage is likely to have a disproportionately greater impact on visual function and quality of life. And establishing a target IOP is a part of art of glaucoma management. And disease progression occurs in some patients despite of reduction of IOP below target pressure. If progression does not occur at an acceptable rate, downward revision of target pressure may be required. The general framework for estimating an appropriate target pressure. ഇപ്പം initial target pressure in case of ocular hypertension, normal visual field and optic disc. So the initial target pressure less than 25 mmHg and 20% below baseline. And mild glaucoma damage, that is optic disc damage with the normal visual field, less than 21 mmHg and 25% below baseline. And moderate glaucoma damage, that's visual field damage in one hemifield outside central technically, and that is 18 mmHg and 30% below baseline. And severe glaucoma damage, the target pressure less than 50 mmHg and 30% below baseline. And there are some risk factors are there that may be that requires the downward adjustment of the target pressure, like history of optic disc hemorrhage, thinner central cornea, history of rapid progression or severe vision loss in the fellow eye, and family history of blindness due to glaucoma and early age of onset of glaucoma damage. And factors that may allow upward adjustment of target pressure, decreased life expectancy or other comorbidities, prior history of stable or slowly progressive damage, higher central corneal thickness.
How do you determine baseline IOP?
Sir?
How do you determine baseline IOP?
Baseline IOP.
It is the presentation IOP actually. Initial measurement of IOP at which we will diagnose the glaucoma. But usually at the baseline IOP, what do you think is like at the baseline IOP, the pressure, the glaucoma is happening in that patient.
Mm.
But it is not true so, because there will be dynamic fluctuations, diurnal variations and fluctuations in the IOP.
Okay, sir.
So it is difficult to determine a baseline IOP in a normal Indian clinical scenarios.
Mm.
So I have to do diurnal variation for the patient, and whatever the highest pressure you will get in the diurnal variation, that you should take it as a baseline IOP,
Yes, sir.
not a single IOP measurement in the clinic. So that's why it is like a more or like a target pressure should be rather than percentages below the baseline, we'll take it as a teens,
Okay,
the
sir.
measurements.
Mm.
Okay, and is there any other target pressure estimation method? It's a glaucoma society. It's saying that early teens, low teens should be there in the severe glaucomas,
Okay,
mid
sir.
teens with the moderate glaucomas, and higher teens or 20, 21 for a early glaucoma.
Okay, sir. Okay, sir.
Because baseline is not accurate.
Okay, sir.
Okay.
And after determining the target pressure, the clinician must decide whether to achieve this goal medically or surgically. Initial treatment of ocular hypertension and most glaucomas typically involves the use of medication or laser trabeculoplasty. Ocular hypertensive agents are divided into several classes and based on chemical structure and pharmacological action. They include prostaglandin analogs, including one agent with the nitric oxide or natriuretic, an adrenergic drug that include beta adrenergic antagonist, beta blockers, non-selective and beta-1 selective. Then adrenergic agonist, non-selective and alpha-2 selective. Then carbonic anhydrase inhibitors, topical and systemic. Parasymptomatic osmotic agent, direct acting cholinergics and indirect acting anticholinesterase agents. Then rock kinase inhibitors, next combination medication and hyperosmotic agents. First is prostaglandin analogs. The mechanism of action is like ocular hypertensive prostaglandin analogs are prodrugs that penetrate the cornea and become biologically active after being hydrolyzed by corneal esterase. They lower IOP by increasing aqueous humor outflow via uveoscleral pathway and decreasing outflow resistance. Precise mechanism by which this change occurs has not been fully determined. The ocular hypertensive prostaglandin analogs bind to various prostaglandin receptors, and that is prostaglandin alpha, F2 alpha, PGF2 alpha, and triggering a cascade of events that lead to activation of matrix metalloproteins. And this lead to remodeling of ciliary body, trabecular meshwork, and scleral extracellular matrix. So the aqueous humor flow through these tissues increased, and topical prostaglandin analogs therapy results in increased space between the muscle vesicles within the ciliary body, which is the primary location of the uveoscleral outflow. So the outflow is increased. Available agents and dosing frequency. Currently, 5 prostaglandin analogs are used, like latanoprost, travoprost, vimatoprost, tafluprost, and latanoprostine bunod. These agents reduce IOP by 25% to 33%. One table is here. Here we can see prostaglandin analogs, concentration, dosing, mechanism of action, everything. Like latanoprost and every prostaglandin analog the common mechanism of action that is increases uveoscleral outflow, and latanoprost also increases conventional trabecular outflow also, and but tafluprost increases uveoscleral outflow only. And this latinoprostein bunod, it increases uvoscular outflow. Nitric oxide may also increase conventional outflow. This is the nitric oxide donating moiety of prostaglandin analog using treatment in glaucoma.
Concentrations are important for every compound to remember you.
Yes, sir. Here we can see latanoprost is 0.005 percentage, and it, then important. Sir, every concentration you have to remember, or sir, we clinically
Yes,
use.
Maximum, most of the drugs you have to remember.
Okay, sir.
Concentration in ophthalmic solutions.
Sir.
Okay.
Hmm. Hmm. The tafloprost appears to be slightly less efficacious than latanoprost, and latanoprost bunod lowers mean diurnal IOP by 32%. It's a nitric oxide donating PGF2 alpha analog. Nitric oxide is thought to increase trabecular outflow facility with the resultant 1 mm Hg IOP lowering advantage over latanoprost in one clinical trial. And prostaglandin analogs are used once daily and are less effective when used twice daily, because some patient may respond better to one agent in this class than to another. Switching drugs after a trial of 4 to 6 weeks may sometimes prove helpful. Adverse effects. An adverse effect unique to this class of drugs is darkening of the iris and periocular skin as a result of increased number of melanosomes within the melanocyte. That without melanocyte proliferation, the number of melanosomes are increasing without proliferation. Increased iris pigmentation is permanent, and the frequency of this effect is depend upon the baseline iris color. And most published data relate to latanoprost and suggest a risk of 33% after 5 years of use. There is no evidence suggests that increased iris or this periocular hyperpigmentation is associated with the risk of melanoma. There is no such risk is identified till now. And this is the pigmentary effect of prostaglandin therapy. This is the appearance of iris before the initiation of treatment, and after, this is after 10 months of therapy. This side effect of increased iris pigmentation occurs primarily in individuals with green brown or blue gray brown iris color. That is pigmentation. This side effect is depending upon the baseline iris color. Other adverse effects are conjunctival hyperemia. That's as a result of vasodilatation. It's more common with bimatoprost and travoprost, and hypertrichosis, trichiasis, and dystiasis. These adverse effects are reversible upon stopping the treatment. Hypertrichosis of eyelashes. This image, eyelashes appear longer, thicker, and increased in number. Use of prostaglandin analog eye drops be associated with the development of prostaglandin associated periorbitopathy. And that include deepening of the upper eye, this upper eye sulcus, upper eyelid ptosis, enophthalmosis, inferior scleral show, and tight orbit. This is right eye of a patient. This is left eye of the patient. And unilateral treatment of topical prostaglandin analog for the left eye. And here we can see left-sided periorbital skin hyperpigmentation. We can see this is, we can see the marginal discoloration. Hypertrichosis, eyelashes is longer than right eye, and deepening of the superior eyelid sulcus also, and also periorbital fat. These abnormalities appear to be the result of periorbital fat atrophy. It is not clear whether it's periorbitopathy is reversible or not after stopping the drug. The development or exacerbation of pre-existing cystoid macular edema can occur in certain predisposed eyes. That's in aphakic eyes, pseudophakic eye with the open posterior capsule, and eyes with uveitis. Reactivation of herpetic keratitis has also been reported. Non-granulomatous anterograditis may occur as an idiosyncratic reaction in approximately 1% of patients. This is, we already discussed the ocular side effects, increased iris, lashes, hypertrichosis, CME, prostaglandin, associated periorbiopathy, everything is same. In case of hematopros sustained release case, conjunctival hyperemia, pain, irritation, and corneal endothelial cell loss, photophobia, and iritis as a ocular side effect. And systemic side effects are flu-like symptoms, joint pain, headache, like that. And same for all the prostaglandin analog.
Last column is important, Shilpa.
Sorry.
Washout period is important in every glaucoma, anti-glaucoma medication. Washout period is important in every group.
Okay, sir.
So that when you want to shift the patient, switching or shifting the patient to other drug, you should see, and especially in steroid responders, you have to see. Washout period is important.
Okay, sir. Washout period of latanoprost is 4 to 6 weeks, and same as same for all the prostaglandin analogs. And peak effect is 10 to 14 hours after installation of eye drop, and maximum IOP lowering effect may take up to 6 weeks to occur. And this is a 2020 update, that is Bimatopro sustained release, that is an intracameral implant composed of bimatoprost in a polymer matrix that causes sustained release of drug. We are discussing it later. And next is adrenergic drugs. First is beta adrenergic, and one is beta blockers. The beta blockers lower IOP by inhibiting cyclic AMP production in the ciliary epithelium. So they are reducing aqueous film production by 20 to 50% with the corresponding IOP, that is 20 to 30% reduction. Healthy eyes, beta blocker administration reduces aqueous secretion and lowers IOP. There is a compensatory reduction in aqueous outflow facility that dampens the magnitude of IOP reduction. The effect on aqueous production occurs within 1 hour of instillation and can last up to 4 weeks after discontinuation of medication. Because systemic absorption occurs, an IOP lowering effect may also be observed in the untreated contralateral eye. Beta blockers have much less effect on aqueous production during sleep, as aqueous production is already reduced during the nocturnal period. Thus, they are ineffective in lowering IOP during sleep. Available agents and dosing frequency. US and Europe, 5 topical beta adrenergic antagonists are approved. Betaxazole, cartenolol, levobutanol, metipranolol, and timolol. Betaxazole is the only topical beta-1 selective antagonist and is less effective in lowering IOP than others, which are non-selective beta blockers. Most beta blockers are approved for twice daily. Many cases, non-selective agents can be used once daily. Generally, dosing first in the morning is preferred in order to effectively blend an early morning pressure rise while minimizing the risk of systemic hypotension during sleep. Many non-selective beta blockers are available in more than one concentration. Clinical experience shown that in many patients, timolol maleate 0.25% is as effective as timolol maleate 0.5% in lowering IOP.
The systemic hypertension during night is there, no? That is important while prescribing beta blockers that is made with timolol. So it should be given early in the evening, so that it has a peak action in within 1 hour, so that during sleep it won't act. So the action of the timolol should be early in the evening.
7 o'clock and morning 7 and evening 7. Is it enough?
Yeah, it's
Better time.
Yeah, 6 and 6 or 7 to 7, not during the sleep. So we have to inquire the patient whether they are taking it that's in just before going to bed. So should not be beneficial for the patient. So beta blockers should give early in the evening so that it should not have any systemic hypotension. It won't cause any systemic hypotension or postural hypotension during the sleep.
Okay, okay. 7 and 8 is the best time, no, BD?
7 and 7 many, or 6 and 6, 12 hours apart. Yeah, continue, Shilpa.
Sir. 10 to 20% of patients treated with the topical beta blockers, IFP is not significantly lowered. Patient already taking a moderate or high dose of systemic beta blocker may experience little additional IOP lowering from the addition of the topical drug. Extended use of beta blocker may result in tachyphylaxis due to receptor upregulation. Adverse effect. Topical beta blockers are generally well tolerated when administered to individuals without specific contraindications. Here we can see the table, and plasma drugs from the topical medication can approach those achieved with the systemic administration because their absorption in the nasolacrimal drainage system and lack of first-pass hepatic metabolism. Administrating topical medication in a gel vehicle system is reduced systemic absorption and decreased plasma concentration of beta blockers compared with the equivalent solution. Punctal occlusion may also reduce systemic absorption. This is beta blockers, non-selective, timolol maleate, and timolol hemihydrate, levobunol, metiprolol, and this is timolol maleate, same like 0.25 and 0.5% both are same in the rate of IUP reduction. And 0.1% gel is also there. And usually its dosing is 1 to BD, gels once daily, sir. Daily. And their mechanism of action is decreasing aqueous humor production, as we discussed before. And ocular side effects like blurred vision, irritation, corneal anesthesia, punctate keratitis, allergy, aggravation of myasthenia gravis. And systemic side effects are like bradycardia. CNS side effects are there, serious side effects are there, and psychotic like mood swings, reduced exercise tolerance, masked symptoms of hypoglycemia, exacerbation of myasthenia gravis. And it's all same for all the beta blockers. And with the betaxazole, there are lower risk of pulmonary complications are there.
So actually, beta blockers are topically well tolerated. So especially we have to look into the systemic side effects.
Sure.
So one more side effect is if you have here it is reduced exercise tolerance and all. So if you want to prescribe in a young active individuals, especially males, there might be an erectile dysfunction also with the timolol. So you have to look into these things whenever you are giving an young active male.
Sure.
So timolol is topically well tolerated. Well tolerated.
Sure.
What do you mean by tachyphylaxis? You have to be very sure, very much concentrated on that when you prescribe timolol.
Sir.
What are have you mentioned about short-term drift and long-term shift?
Short-term shift, long-term shift.
Short-term drift and long-term shift.
No, sir.
You just read and write it down.
Short-term drift. Once more, sir.
It is there.
No, sir. Short-term
shift
and long-term drift, sir. Here is there, sir.
That
but
is
it's not explained. Not explained, sir.
That is due to tachyphylaxis only. And you just write it down.
Okay, sir.
So what you have to see is whether the patient is on timolol. If the patient is on timolol on continuous usage, what will happen?
Okay, sir.
Mean by tachyphylaxis exactly.
Okay, sir.
Some people tell they are getting sleep. Is there any relation after using these drugs?
I think it is due to adrenergic agonists, ma'am, rather than due to beta blocker. That is due to brimonidine.
Okay.
Not due to timolol.
Brimonidine. Okay. Why?
It will cause some blood-brain barrier. It will cross the blood-brain barrier. So it may cause some CNS depressions in some patients, especially in younger individuals. We don't give children. We don't give.
Okay.
They cannot tell the symptoms exactly. So that's why in children we are not giving brimonidine.
Okay.
In elderly individuals also, it may cause blood-brain barrier and cause CNS depressions in some centers. So
Elderly patients also.
Elderly patients, yes.
Elderly. Okay. Thank you.
And washout period for all beta blockers is 1 month. Peak timing that is varying but washout is 1 month for all beta blockers. Okay. Systemic adverse effect to beta blockers, like we discussed, pulmonary like bronchospasm, cardiac bradycardia, increased heart block, systemic hypertension, reduced exercise tolerance, and CNS depression. Patient with diabetes mellitus may experience reduced glucose tolerance and masking hypoglycemic signs and symptoms. And abrupt withdrawal of ophthalmic beta blockers can exacerbate symptoms of hyperthyroidism. Beta blocker, before beta blocker is prescribed, the clinician should ask whether patient has asthma, and that's why beta blockers may induce severe life-threatening bronchospasm in susceptible patients. And beta 2 receptors are present in bronchial smooth muscle cells, and their inhibition results in bronchospasm in those patients. And betaxazole is a beta 1 selective antagonist, is safer than the non-selective beta blocker for use in patient with asthma. And betaxazole may be less likely to cause CNS depression also. Prior to initiation of therapy with the beta blocker, the patient pulse may be measured, and beta blocker should be withheld if pulse rate is low or if more than first degree heart block is present. Because we know that one of the cardiac side effects of beta blocker is bradycardia. And administration of topical beta blockers has been associated with the development of signs and symptoms of myasthenia gravis in patient without pre-existing diagnosis, and can exacerbate the condition in patient already known to have the disease. And mechanism by which it occurs is unclear. This myasthenia gravis. And other adverse effects of beta blockers include lethargy, moods in the system, like the psychotic, like side effects, and visual disturbances, corneal anesthesia, punctate keratitis, impotence, reduced libido, alteration of serum lipids, reduction in HDL is more. And in children, beta blockers should be used with caution because relatively high systemic levels they will get achieved while topical medication. Next.
So we have to highlight the allergic side effect of the drugs. Okay.
Yeah.
So in both the things, prostaglandins and beta blockers, both, and even adrenergic agonists, all these are prone for getting allergies. So we have to highlight that thing, and we should be for checked for follicular type of conjunctivitis whenever patient comes and complaining of redness and itching. Just not seeing the conjunctival hyperemia, and it may be a side effect. We should not leave like that.
Okay, sir.
And one more thing is, I just want to highlight about the cardiac contraindication for beta blockers.
Sure.
Okay, it is like what you told is heart blocks.
First degree, only first degree.
Usually, the electrical conduction abnormalities in the heart are the major contraindications for not prescribing beta blockers.
Okay.
But in coronary artery diseases, what we see usually in myocardial infarctions, or any patient is on like post CABG or post PTCA stunting, we have to, if possible, we have to go through their cardiac case sheets. If it is not possible, we just want to rule out the blocks. If there are no blocks, we can still prescribe timolol. If it is just in coronary artery disease with a status post CABG or status post PTCA, still we can give timolol. It is not completely contraindicated. Usually in systemic drugs also, beta blockers will remodel the they help in remodeling of myocardial tissue.
Okay, so tissue.
If at all they are in a congestive cardiac failure also,
Helpful.
cardiologists will prescribe beta blockers.
Ah.
So just patient is cardiac disease, patient is having cardiac disease, that is not in contraindication for timolol prescription. So we have to make sure that there are no conduction abnormalities in the heart.
Okay, sir.
Then we can prescribe. If it is conduction abnormalities are there, then we should not.
Okay, sir.
Continue.
Next, adrenergic agonists. First is non-selective. They are only epinephrine, that's adrenaline, and dipepinephrine, which is a prodrug of epinephrine. They reduce aqueous humor production, increase uvoscleral outflow, improve conventional outflow facility. But these has been superseded by other class of drug. Now used in they are now using in the management of glaucoma only rare cases due to the frequent occurrence of local adverse effects. And we can see here, we can see alpha 2, alpha, no. Okay. This is this is a side effect of epinephrine, that brown conjunctival deposits. This condition was caused by epinephrine drops. In this picture, you can see brown color deposits caused by the epinephrine drops. And next is alpha 2 selective adrenergic agonist. The mechanism of action: lower IOP primarily by reducing aqueous humor production, and alpha 2 receptor found in the ciliary epithelium is coupled to an inhibitory G protein. It's thought that there is when this adenoreceptor is bounded by catecholamines or pharmacologically active agonist, the intracellular cascade results in reduction in the activity of adenylate cyclase, and then cyclic KMB is also reduced, which resultant reduction in the rate of aqueous humor production. An alternate or possibly complementary mechanism by which aqueous humor production is reduced may be this anterior segment vasoconstriction and reduced blood flow to the ciliary body. So the production is decreased. After a long period of therapy, increased vascular outflow was observed with selective alpha 2 adrenergic agonist brimonidine, but not with apraclonidine. How vascular outflow may be increased with the brimonidine is unclear. Evidence points to relaxation of ciliary smooth muscle cells. As with the beta blockers, systemic absorption of this agonist also lead to a crossover effect. Next, available agents and dosing frequency. Brimonidine tartrate, most commonly used alpha 2 adrenergic agonist. Naproxen hydrochloride is a alpha 2 adrenergic agonist and clonidine derivative, used for long-term therapy only in rare instances, because tachyphylaxis and hypersensitivity reaction that can cause blepharoconjunctivitis. Use of apraclonidine is mostly limited to perioperative administration. To blend, acute IUP spikes may occur after laser iridotomy, laser trabeculoplasty, India laser capsulotomy, and cataract extraction. Brimonidine also have similar effective when used perioperative. Tachyphylaxis is less profound with brimonidine than with the apraclonidine. Brimonidine peaks IOP reduction is approximately 26%. That is 2 hours post-dose, which is comparable to the reduction achieved by non-selective beta blockers and superior to that of selective beta blocker petaxazone. Studies have shown that brimonidine does not lower nocturnal IOP, but approved for therapy 3 times daily in US, and brimonidine is commonly used twice daily. particularly when used in combination with at least one other agent. Here we can see apraclonidine hydrochloride we can 20 to 30% reduction in production, this acosuma production, brimonidine also 20 to 30% production. And here we can see useful in pre or post laser or cataract surgery tachyphylaxis, and peak less than 1 to 2 hours, like washout is 1 to 2 weeks. And brimonidine tartrate is highly selective for alpha-2 receptor. Brimonidine should not be used in infants and young children. The peak is 2 hours. Washout is same 1 to 2 weeks. Then adverse effect. The incidence of ocular allergic reactions like follicular conjunctivitis and contact blepharodermatitis then is lower with brimonidine than with apraclonidine. This is a delayed type of hypersensitive reaction, and this is dose dependent also. With a 1 year incidence of approximately 15% for brimonidine tartrate, 0.2% preserved with the benzalkylonium chloride, 10% for brimonidine tartrate, 0.15% preserved with the sodium chloride. That's true, right? And granulomatosis antinucleate is rare but has been reported in association with the use of brimonidine. This is picture showing contact blepharodermatitis following alpha-adrenergic agonist use. And
so
here
it is
we can
very important with when compared when came to brimonidine.
Sir.
It is not the immediate reaction.
Sir.
Immediately the patient will be fine with the brimonidine.
Sir.
After usage of say some certain period, some 4 to 5 months, it will vary from patient to patient. But they came up with the follicular type of conjunctivitis with associated with blepharitis.
Sir.
So yeah, delayed type of hypersensitivity is important in case of brimonidine.
Sir. Here this picture, allergic reaction from brimonidine use with injection and follicles. Typical allergic reaction with the brimonidine as a follicular conjunctivitis that occurs months to years after long-term use. This in this upper two pictures, contact dermatitis after use of brimonidine shows in this picture, lower picture. Skin changes.
It is reversible. If you stop the drug and treat with the steroids, it's reversible.
Sure.
And we should not forget about the neuroprotective action of brimonidine.
Sure.
As we discussed when we discussed about pathogenesis of glaucoma, it inhibits the calcium-induced apoptosis of retinal ganglion cells in the posterior segment. Okay.
Sure.
So that neuroprotective action is also there for brimonidine.
Sure.
We should not forget that.
Sure.
You didn't mention about that in mechanism of action.
Is this allergic reaction is related to only brimonidine, the drug itself, or preservative? Is there any relation?
It is there, madam. Actually, alpha-gan Z, whatever we are using commercially, it is with the purite.
Okay.
So even with the Z also, with the purite also, will get that allergic reaction. The compound itself has a delayed type of hypersensitivity. But BAK, benzyl alkylonium chloride, is having allergic. Is also having allergic type of allergic reaction side effect. But brimonidine, the compound itself has that allergy.
Okay, thank you.
Alpha-2 selective agonists have some alpha-1 binding activity, and the ocular effects of alpha-1 adrenergic agonists include conjunctival vasoconstriction, pupillary dilatation, and eyelid retraction. Apraclonidine has a much greater affinity for alpha-1 receptors than brimonidine, so they are producing more alpha-1 effect. In some patients, apraclonidine causes mydriasis, whereas brimonidine commonly causes miosis. Systemic adverse effect to alpha-2 agonists include xerostomia and lethargy, both mediated by their clonidine-like CNS activity. Patient taking this medication should be advised to perform punctal occlusion to minimize systemic consumption. Brimonidine should not use in infants and young children because of the CNS depression, apnea, tachycardia, and hypotension, due to a combination of the lower volume of distribution and presumed increased CNS penetration of the drug in children. Monoamine oxidase inhibitors and tricyclic antidepressant may interfere with the metabolism of aproclonidine and brimonidine, resulting in toxicity. So we have to inquire about history of any psychiatric medication. Like carbonic anhydrase inhibitors. Next, this mechanism of action, carbonic anhydrase inhibitors decrease aqueous humor production by inhibiting the activity of ciliary epithelial carbonic anhydrase enzyme. Systemic CAI therapy may further decrease aqueous humor production formation because of the resultant renal metabolic acidosis. They produce reduce the activity of sodium potassium ATPase in ciliary epithelium. The enzyme carbonic anhydrase is present in many tissues, like corneal endothelium, iris, retinal pigment epithelium, and red blood cells. Epithelial cells lining in choroid plexus of the brain and kidney. More than 90% of the ciliary epithelial enzyme activity must be inhibited to decrease aqueous production and lower IOP. That's 90% of enzyme activity should inhibit it. Like carbonic anhydrase inhibitors like acetazolamide. Oral one is acetazolamide, and acetazolamide we can give parenteral also. Then the systemic methazolamide, topically dorzolamide and brinzolamide. Acetazolamide and methazolamide we can give orally, and topical dorzolamide and brinzolamide. The topical agents, dorzolamide and brinzolamide, they are available for long-term treatment of elevated IOP associated with the fewer systemic adverse effects than our systemic carbonic anhydrase. In US, these agents are currently approved for 3-time use, but most clinicians twice daily prescription giving. Dosing 3 times per day results in slightly greater IOP reduction. The systemic carbonic anhydrase inhibitors can be given orally or intravenously and are most useful in patients who present with severely elevated IOP or as a temporizing measures until surgery can be performed. Oral carbonic anhydrase inhibitors begin to act within 1 hour of administration with maximal effect within 2 to 4 hours, where IV agent act within 15 minutes and sustained release acetazolamide can reach a peak effect within 3 to 6 hours of administration. Because of the adverse effect of systemic drugs, long-term therapy should be reserved for patients whose IOP is not controlled with topical therapy and who have refused surgery or whom surgery would be inappropriate. The most commonly used oral drug are acetazolamide and methazolamide. Methazolamide has a longer duration of action, less bound to serum protein than acetazolamide. It's also less effective than acetazolamide. Methazolamide and sustained release acetazolamide are the best tolerated of the systemic carbonic anhydrase. Methazolamide is metabolized by liver, where acetazolamide excreted by the kidney, not metabolized. So, used with caution and at an adjacent dose in patient with renal insufficiency. Oral carbonic anhydrase are potent medications that are associated with a significant adverse effect. The lowest dose that reduces the IOP to an acceptable range should be used. Methazolamide often effective in doses as low as 25 to 50 milligram, 2 to 3 times daily, and sustained release formulations of acetazolamide may have fewer adverse effects than standard formulation. The typical adult dosage of acetazolamide is 250 milligram 4 times daily for the sustained formulation or 500 milligram twice daily for the sustained release formulation. Standard formulation 250 milligram 4 times and sustained release 500 milligram twice. Here we can see acetazolamide 125 milligram, 250 milligram, 500 milligram is sustained release. And parenteral 500 milligram, that's according to the weight of 5 to 10 milligram per kilogram. Methazolamide is 25 milligram and 50 milligram. And topical 2%, dorzolamide is 2% and brinzolamide is 1%. And here, ocular side effects are in case of acetazolamide, no side effects, and methazolamide is also no side effects. And in case of dorzolamide and brinzolamide, there are ocular side effects like induced myopia, blurred vision, stinging keratitis, punctate keratopathy, and conjunctivitis, dermatitis is there. And in compared to dorzolamide, brinzolamide has less stinging and that corneal and keratopathy is less prominent. And systemic side effects like poor tolerance of carbonated beverage in case of oral drugs like acetazolamide and methazolamide. They show systemic side effects like poor tolerance to carbonated beverages. This can cause acidosis, depression, malaise, hirsutism, flatulence, paresthesis, numbness, lethargy, blood. We will discuss later here. Common adverse effect of topical carbonic anhydrous include taste disturbance, blurred vision, and burning up of insulation and punctate keratopathy. Common for everything and topical common for topical carbonic anhydrous inhibitors, and burning up of insulation particularly common and more intense with the dorzolamide. That's a solution formulated at a low pH due to the low solubility of the molecule at physiologic pH levels. So burning is more. Use of brinzolamide suspension results in white deposits in a tear film. Eyes with compromised endothelial cell function may also be at a risk of corneal decompensation with the use of either of these drugs. And dorzolamide allergy, dryness and excoriation of skin along with the leads we can see in this picture. And adverse effect of systemic carbonic anhydrous therapy are usually dose-related and are driven primarily by the resultant metabolic acidosis. And patient experience paresthesis of fingers and toes, loss of energy, anorexia, weight loss, which is common, and mental depression is severe mental depression, abdominal discomfort, diarrhea, loss of deep libido, impotence, and taste disturbance, which is taste disturbance, especially with the carbonated beverage. And patient with sickle cell anemia are at a risk of sickle cell crisis because of dehydration. And there is an increased risk of formation of calcium oxalate and calcium phosphate renal calculi. Because methazolamide causes less acidosis, so it may be less likely than acetazolamide to cause nephrolymphasis of stone formation. As the urine become more alkaline, ammonia excretion is reduced. Systemic carbonic anhydrase are contraindicated in patients with hepatic cirrhosis because they are either systemic agent can precipitate hepatic encephalopathy due to increased serum ammonia levels. Carbonic anhydrase are sulfonamides and cause allergic reaction in patient with non-sulfonamide antibiotic allergies. But this patient, like only 10% of patient with hypersensitivity to sulfonamide antibiotic experience allergic reaction when exposed to sulfonamide non-antibiotic drugs. Aplastic anemia and other blood crises, Steven-Johnson syndrome and hepatic necrosis are very rare but potentially fatal idiosyncratic reaction to carbonic anhydrase inhibitor. Routine complete blood count suggested before starting, and hypokalemia is a potentially serious complication that is especially likely to occur when oral carbonic anhydrase is used concurrently with the other drug that causes potassium loss, that thiazide diuretic and for hypertension. Severe serum potassium should be monitored regularly in such patients when we are giving oral carbonic anhydrase inhibitors.
So here carbonic anhydrase inhibitors topical has also proposed to have increased ocular blood flow to the optic nerve. So optic nerve head perfusion might be increased with the topical CA carbonic anhydrase inhibitors. And also one more point is brinzolamide is proposed to have a neuroprotective effect when compared to dorzolamide. So these two also should be kept in mind.
Sir, only 50 slides are complete. No, sir, 50. 60. 74 slides complete, sir. 122.
Still 50 slides are there, no?
Sir. Next is no, next parasympathetic, sir.
Yeah, still 60 slides are there.
60 slides are there, sir.
Okay. Shall we continue tomorrow?
Yes, sir. Next parasympathetic draw kinase mixed formulation, hyperosmotic, then how to instill drops, then combination like that, sir.
Okay. Any other add-on points, ma'am?
Sir, one doubt, sir.
Yeah.
Sir, this neuroprotective effect means, sir, it's CNS protective or it's protective for retina, sir?
ONH.
Optic nerve head. Okay,
Optic
sir. Okay, that
optic nerve head and retinal ganglion, sir.
Okay, sir. So their optic nerve, the cupping like that will be.
We have read the mechanical and vascular theories for pathogenesis, no? Pathogenesis of glaucoma.
Yes, sir.
And also there are neuroprotective mechanisms, no? Like excitotoxicity.
Sir. Excited.
Apoptosis. These are targeted by these neuroprotective agents.
Sir. Okay, sir.
All the other drops which we are talking about is like how to reduce the IOP.
Sir.
That is a mechanical. They are targeting at mechanical pathogenesis and also vascular sometimes.
Sir.
Neuroprotection we are talking about. There is glutamate induced excitotoxicity, nitric oxide inhibition,
Sir.
and calcium induced apoptosis. These things.
Sir, in timolol we are both 0.25 and 0.5% are effective. Both are same effect.
Commercially, 0.5 is available in our Indian pharmacy. And also that bitoxolol, I just want to mention, it is a cardioselective.
Sir.
It is like they are. What is meant by cardioselective?
They won't act on like beta.
Beta 2. It is beta 1.
Selective.
Beta 2 is pulmonary, so that you can give in asthmatic patients. So timolol is non-selective, so it will inhibit both beta 1 and beta 2.
We cannot give in asthma patient.
Asthma, but cardioselective is not to give in cardiac patients. Cardioselective is to give in pulmonary patients. Okay. Beta 1 receptor, beta 1 selective is bitoxolol. So you can give it in asthma patients, not in cardiac.
Cardiac patients.
And previously there was commercially available levobunolol also, but because of its inefficiency, they have removed from this thing. So levobunolol is not available commercially as of now. And sometimes bitoxolol is available, but it is also in less numbers.
Peak time is very less for bitoxolol.
Yeah. And its mechanism, IOP reduction is also less compared to timolol.
15 to 20% only.
Yeah. So,
sir, for this, before starting all these beta blockers and alpha 2, like all these drugs, we are sending patient for a cardiac evaluation, sir.
No need. We'll ask for a history. And we have to, as you mentioned, we have to palpate the pulse before prescribing timolol. If the patient is having any bradycardia, we should be checked. Patient should have checked for a cardiac.
Okay, sir.
This thing.
Okay.
Irregular pulse or a low pulse, bradycardia. These things should be checked. And I just want to highlight one more thing is like within the prostaglandin loop, we can shift to another prostaglandin if one is not effective or one is not tolerating. So if the patient is allergic to latanoprost, we can still try giving travoprost or bimatoprost. Okay. And these drugs are available as unions in Western countries. So that you will have only one drop in that union. You can discard that, and no need to store it in our place. So contamination and efficacy can be prevented with the unions, but it is not cost effective in our scenarios. Yes. So tafluprost is also available as unions only, but not in. Tafluprost is not available as 3 ml or 5 ml packs. Any other comments, sir? It's a good presentation, Shilpa. Just to highlight those things.
Sir.
So whatever mentioned, that tachyphylaxis, you just elaborate for a beta blocker.
Sir.
They used to ask in Vivas.
Sir.
Right. So just elaborate on the tachyphylaxis. What is short-term drift and long-term shift? And also you just read about neuroprotection also.
Sir.
Yeah, with this we can conclude the meeting, I think.
Sir. Okay.
Padma,
Thank you.
Okay, Shilpa, we'll conclude the
Thank you, sir.
Thank you.
Thank you, ma'am.
Nice presentation, Shilpa.
Thank you, ma'am.